Welcome, curious minds, to another profound journey into the very mechanisms that govern our bodies. Today, we're diving deep into a topic that, well, while often operating silently beneath the surface, impacts an astonishing number of lives with devastating consequences. Think about this. Heart disease alone accounts for approximately 1 in 4 deaths in the United States every
Yeah,
single year.
1 in 4. It's huge.
That's a staggering 655,000 Americans annually lost to a condition that often has a tiny yet incredibly powerful event at its core, a blood clot.
It's an immense public health challenge, truly. When we talk about heart disease, we're, encompassing conditions that led to about 365,914 deaths from coronary disease just in 2017 alone.
Wow.
And the sheer volume of events is equally startling. Around 805,000 heart attacks and 795,000 strokes in the US in that same year.
Just staggering numbers.
But the impact of blood clots isn't limited to the arteries. You've got deep venous thrombosis, or DVT, and its dangerous cousin, pulmonary embolism, PE. They affect an estimated 600,000 people annually. That contributes to another 60,000 to 80,000 deaths each year. These aren't just cold statistics. They represent a significant portion of the illness and mortality burden across a wide spectrum of both arterial and venous diseases.
Absolutely. So, what is this phenomenon that can be both life-saving and, well, life-threatening? At its core, blood clotting is one of our body's most intricate and incredible defense mechanisms. It's the process, technically known as haemostasis, that prevents us from bleeding out from even a simple paper cut. It's a delicate, finely tuned symphony of biological processes designed to quickly seal a breach in a blood vessel.
A vital process.
But, as with all powerful biological systems, there's a flip side. Sometimes, these very same, normally protective processes, in specific settings, can go awry. Instead of forming a protective plug at a site of injury, they can create an unwanted clot that obstructs blood flow, causing tissue damage from lack of oxygen. This harmful, uncontrolled clot formation is what we call thrombosis.
Right.
And understanding this crucial distinction between beneficial hemostasis and harmful thrombosis is at the very heart of our deep dive today.
And that's exactly our mission. We're here to give you a shortcut, almost a fast track, to mastering the complex intricacies of both arterial and venous thrombosis. Our insights today are distilled directly from Chapter 117 of an authoritative medical text. Think of this as your pathway to understanding, at a truly professional level, how blood clots form, why they matter so profoundly for human health, and what distinguishes their various forms.
But we're really aiming for that elite professional understanding here.
Exactly. We want to equip you with that level of understanding without getting you lost in dense, overwhelming medical jargon. Our goal is to make these profoundly important concepts accessible, drawing out every essential nugget of knowledge.
That's right. We've gone through this highly detailed and comprehensive source, uncovering the fascinating science, pulling out every essential nugget. This isn't just about memorizing facts. It's about grasping the why and how behind this complex, vital, and often misunderstood world of blood clotting. So let's unpack this. So we're starting with the fascinating dual nature of blood clotting. Physiologic hemostasis, the body's protective mechanism versus pathologic thrombosis, the dangerous disease-causing counterpart. It's truly a tale of two processes, where one is absolutely vital for sustaining life and the other can, tragically, be life-ending.
Precisely. Let's start by looking at thrombosis as the silent threat. Fundamentally, it's the obstruction of blood flow due to the formation of an unwanted clot, known as a thrombus. When this happens, the tissue or organ downstream from that clot is starved of oxygen, a condition medically termed anoxia, which inevitably leads to tissue damage and dysfunction.
Anoxia, lack of oxygen.
Yeah.
Got it.
And as we touched on earlier, this process is a major contributor to illness and death across a broad spectrum of arterial diseases, like heart attacks and strokes, and venous diseases like deep vein thrombosis and pulmonary embolism. Its impact is truly pervasive in modern medicine.
And the scale of this impact is truly staggering, isn't it? When we consider the arterial side, heart disease alone accounts for about 1 in 4 deaths in the U.S. every year.
1 in 4 still resonates.
To really put that in perspective, in 2017 alone, coronary heart disease was directly responsible for 365,914 deaths, and the events themselves are shockingly common. 805,000 new or recurrent heart attacks and 795,000 strokes.
Huge numbers.
These aren't just abstract numbers. They reflect the widespread and profound nature of arterial thrombosis, touching countless lives and families.
And beyond the arterial side, we have the equally, if not more, insidious threat of venous thromboembolic disease, or VTE, which encompasses PE and DVT. It's estimated that as many as 600,000 people experience a PE or DVT annually in the U.S. These events contribute to 60,000 to 80,000 deaths each year, and many are sudden and unexpected.
Wow.
This silent threat can often go undiagnosed until it's too late, underscoring the immense burden thrombosis places on public health.
So here's where we get to that crucial distinction that truly helps us understand the genius and the vulnerability of our bodies.
Yeah.
Physiologic hemostasis versus pathologic thrombosis.
Right, the good versus the bad clotting, essentially.
Exactly. On one hand, hemostasis is the body's magnificent normal process of stopping bleeding after an injury. Imagine you cut your finger. Within seconds, a complex dance of cells and proteins begins to form a plug, preventing uncontrolled hemorrhage or exsanguination. It's a delicate interplay, a finely tuned balance between factors that promote clotting and factors that inhibit it, usually favoring just enough clot formation to seal the wound. It's literally what keeps us from bleeding to death from a simple scratch.
And on the other hand, pathologic thrombosis is when those very same processes that are so essential for normal hemostasis instead lead to harmful, unwanted clot formation, causing vessel occlusion where there's no injury or where the clot grows far beyond what's necessary. It's like the body's own highly effective defense system, which is critical for survival, turning against itself.
Like the system goes rogue.
Precisely. This is the heart of why thrombosis is a disease.
What's particularly fascinating and a constant challenge for doctors is that even many commonly used therapeutic interventions treatments designed to heal or manage one condition can inadvertently alter this delicate thrombotic hemostatic balance.
Unintended consequences?
Meaning, a drug or procedure meant to help in one area might, in some cases, adversely affect how our blood clots, tipping the scale towards either unwanted bleeding or dangerous clotting.
Yeah, it's a tightrope walk.
This really highlights the incredible complexity doctors face when managing patients, walking that delicate tightrope of ensuring safety while providing effective care. Moving on, we're going to unravel something truly intriguing. Acquired inhibitors of coagulation factors.
Yes, this is where things get really interesting.
This is a remarkable and often very dangerous situation where the body essentially turns on itself, producing antibodies that interfere with its own finely tuned clotting mechanisms. It's like your immune system, instead of fighting off invaders, starts attacking the very machinery that keeps your blood clotting normally.
Yes, and first, let's dive into acquired factor VIII inhibitors. This is a critical distinction from inherited hemophilia, which many might be more familiar with.
Right, hemophilia is genetic, this is acquired.
Exactly. In inherited hemophilia, there's a genetic deficiency of factor VIII, and common symptoms include joint bleeding or hemothrosis. But in acquired FV8 inhibitors, joint bleeding is rare. Instead, you can see sudden, severe, and potentially life-threatening internal bleeding, such as retroperitoneal hemorrhages, that's bleeding behind the abdominal lining or even into muscles or the brain.
That sounds incredibly serious.
It is. This sudden, severe bleeding can be incredibly dangerous, with overall mortality rates ranging from a worrying 8% to 22% in untreated patients. Most tragically, deaths can occur rapidly within weeks of the initial presentation due to uncontrolled bleeding.
So given how suddenly and severely this bleeding can manifest, how do doctors even begin to diagnose something so rare and critical? What are the telltale signs in the lab?
That's a good question because the diagnosis relies on a careful interpretation of laboratory tests. You'll typically observe a prolonged activated partial thromboplastin time, or APTT. This test measures how long it takes for blood to clot through a specific pathway.
Okay, so the APT is longer.
Right. Crucially, however, you'll also find normal prothrombin time, PT, and thrombin time, PT. The real diagnostic linchpin, and this is truly important for that elite understanding we mentioned, is something called a mixing study.
A mixing study, what does that involve?
In this test, a patient's plasma, which has the prolonged APT, is mixed with normal pooled plasma. If the prolonged APT does not correct or significantly shorten, it strongly indicates the presence of an inhibitor in the patient's blood, rather than simply a deficiency of a clotting factor.
Ah, I see. So if adding normal plasma doesn't fix the clotting time, something in the patient's blood is actively blocking it.
Exactly. If it were just a factor deficiency, adding normal plasma would supply the missing factor and correct the clotting time. But if there's an antibody actively inhibiting the factor, it continues to block the process even with the normal plasma added.
Makes sense. So the mixing study essentially helps you differentiate between a missing part in the clotting machinery versus someone actively trying to gum up the works. And then, how do you confirm it's specifically a factor VIII inhibitor?
Precisely. To confirm the specific inhibitor, they use a Bethesda assay. This test, similar to how they detect inhibitors in inherited hemophilia, uses factor-specific deficient plasma to confirm the presence and quantify the strength of the factor VIII inhibitor.
Okay, the Bethesda assay nails it down.
Right. Once diagnosed, treatment typically has two main prongs. First, immediate control of any life-threatening bleeding, and second, eradicating the inhibitor itself. For immediate bleeding, particularly severe internal bleeds, activated bypass products are vital. These include activated prothrombin complex concentrate, or APCC, or recombinant factor A, or RFVIA.
Bypass products.
Yeah.
Because they skip the black step.
Exactly. They're called bypass products because they activate clotting downstream of factor VIII, effectively bypassing the inhibited step. For acquired FE8 inhibitors specifically, recombinant porcine F8, which is a pig-derived factor VIII, can also be used as it may not be recognized by the human antibody. There are even newer emerging therapies like emicizumab, a bispecific antibody, which is currently undergoing trials in Europe for this patient population, showing promise in potentially rebalancing the clotting system.
And unlike inherited hemophilia, where inhibitors can be notoriously challenging, you mentioned that these acquired inhibitors are typically responsive to immune suppression. What does that involve, and what's the long-term outlook?
Yes, that's a key difference. Immune suppression is the core strategy for eradicating the inhibitor, as these antibodies are produced by the patient's immune system. The first-line treatments are typically high-dose glucocorticoids, like prednisone, often combined with cyclophosphamide, and immunosuppressant.
So dampening the immune system that's making the antibody.
Correct. This combination is effective in achieving remission in about 70% of patients. While other alternatives, such as high-dose intravenous gamma globulin, or IVIG, and anti-CD20 monoclonal antibodies, like rituximab, have been reported as effective, there's no firm evidence yet that they are superior to the conventional first-line options.
Okay.
It's also crucial for patients and clinicians to understand that relapse of an inhibitor to FES is relatively common. Studies show it can occur in up to 20% of patients within the first 6 months after withdrawing immunosuppression.
20%, that's quite high.
It is. So regular, diligent follow-up with blood tests is absolutely essential to monitor for recurrence. This condition truly requires a comprehensive and long-term management strategy.
Next, let's talk about another surprising and dangerous source of acquired inhibitors. Antibodies to topical thrombin preparations.
Ah, yes, the surgical complication.
This is truly a surgical complication that can arise unexpectedly, yet with potentially life-threatening consequences.
Indeed. Topical plasma-derived bovine and human thrombin are very commonly used as hemostatic agents during major surgeries, cardiovascular, thoracic, neurologic, pelvic operations, and also in trauma patients with extensive burns. They're directly applied to stop bleeding fast.
Right, applied right onto the bleeding site.
Exactly. However, the mechanism of harm here is quite fascinating and a bit of a medical curveball. Antibodies can form against the foreign bovine thrombin or even its contaminants, particularly when it's plasma-derived. What's truly problematic is that these antibodies can then cross-react with human clotting factors, particularly human factor V and even human thrombin itself.
Cross-react, so the antibody attacks the human factor too.
Precisely. This cross-reactivity can lead to severe, life-threatening bleeding episodes, often days or weeks after the surgery where the topical thrombin was used. There have even been reports of antibodies to factor V, specifically with the use of topical preparations of recombinant human thrombin, showing it's not just the bovine source that can cause issues.
That's incredible. So a product designed to stop bleeding could inadvertently trigger a severe, widespread bleeding disorder later on. This sounds like a diagnostic nightmare, especially when the initial bleeding might simply be attributed to the surgery itself.
It absolutely is. The diagnosis is rare, and it's complicated by the fact that bleeding occurring during or immediately after major surgery might simply be wrongly attributed to the surgical procedure itself, masking the underlying antibody issue.
Right. You'd just assume it was surgical bleeding.
Exactly. This is why a careful medical history is so important, often for decades back. The risk of developing these cross-reacting antibodies is significantly increased by repeated exposure to topical thrombin preparations.
Repeated limited exposure, so someone could have had it years ago.
Yes, a patient might have had a surgery 10 or 20 years ago where topical thrombin was used and then developed the antibodies after a second exposure. This makes a thorough past medical and surgical history absolutely critical for assessing the risk.
What about the lab tests for this condition? How do they differ from the factor VIII inhibitor we just discussed, which also causes a prolonged APT?
The lab abnormalities for antibodies to topical thrombin preparations are distinct and frankly quite challenging to interpret. You'll typically see a combined prolongation of both the APTT and the PT.
Both are prolonged here. Okay.
Yes, unlike the factor VIII inhibitor, which primarily affects APTT, and critically, a mixing study where patient plasma is mixed with normal plasma fails to improve the clotting times, even with transfusions of fresh frozen plasma, or FFP, and vitamin K. This indicates an inhibitor rather than a simple deficiency. The specificity of the antibody, meaning which clotting factor it's attacking, is then determined by measuring the residual activity of human factor V or other suspected clotting factors.
But you said there are no specific tests for this.
Correct. A very important point for clinicians and advanced learners is that no specific assays for bovine thrombin coagulopathy are commercially available, making definitive diagnosis incredibly challenging and often based on clinical suspicion and exclusion.
So without specific assays or established guidelines, how do they treat something so rare and complex?
That's the real challenge. No established guidelines exist for the management of acquired inhibitors to topical thrombin. Reported approaches have included platelet transfusions, as platelets can be a source of factor V replacement for those with factor V inhibitors. Fresh frozen plasma and vitamin K supplementation may be used, but primarily as coadjuvants to support general clotting, not as effective treatments for the underlying coagulopathy caused by the antibodies.
So they help a bit, but don't fix the root cause.
Right. Experience with recombinant factor A as a bypass agent, while tried, is limited, and unfortunately, outcomes have been generally poor, highlighting the severity and recalcitrance of this condition. Sporadic reports exist of immune suppression with glucocorticoids, intravenous immunoglobulin, IVIG, or serial plasmapheresis to try and eradicate the antibodies, but success is variable.
And the key advice?
Perhaps the most crucial piece of advice for patients who develop this condition is to avoid any topical thrombin sealant in the future, as re-exposure could lead to devastating consequences.
Makes sense. Finally, in this section, we touch on the lupus anticoagulant, a truly paradoxical clotting disorder, one that often surprises people because of its name.
Indeed. Despite its name, which suggests an anticoagulant effect, the lupus anticoagulant is primarily associated with venous or arterial thrombotic disease.
So it causes clots, not prevents them.
Usually, yes. It paradoxically predisposes patients to clotting, not bleeding, in the body. It's often found in patients with autoimmune conditions like systemic lupus erythematosus, but it can occur in others as well. However, in a rare and particularly perplexing paradox, it can sometimes also be associated with bleeding. This bleeding typically occurs due to antibodies against prothrombin, a key clotting factor, which leads to hypoprothrombemia or abnormally low levels of prothrombin.
So it's called an anticoagulant because of how it behaves in lab tests, often prolonging clotting times. But in the body, it typically leads to dangerous clotting. How do you distinguish it from the other acquired inhibitors we just talked about, especially since all of them can cause a prolonged APT that doesn't correct on mixing?
That's the key challenge and an important nuance for a deep understanding. While all these acquired inhibitors share that common feature of a prolonged APT that doesn't correct on mixing, the crucial distinction for the lupus anticoagulant lies in two specific laboratory tests: the dilute Russell Viper venom time, DRVVT, and the hexagonal phase phospholipids test.
Okay, DRVVT and hexagonal phase phospholipids.
Yes. These specialized tests specifically look for the presence of antiphospholipid antibodies, which are characteristic of lupus anticoagulant. They will be negative in patients with an acquired factor VIII inhibitor or an antibody to topical thrombin, but they will be positive in those with lupus anticoagulants.
Ah, so those tests were the differentiators.
Exactly. This allows clinicians to differentiate between these distinct, albeit sometimes similar looking in initial lab screens, conditions, and guide appropriate treatment. It truly highlights the sophistication required in diagnosing these complex clotting disorders.
Okay, let's switch gears dramatically now and dive deep into arterial thrombosis. This is truly the engine of heart attacks and strokes, and here our focus shifts squarely to the remarkable tiny enucleate cell, the platelet.
That's absolutely right. In arterial occlusion, the primary players are platelets and abnormalities of the vessel wall, particularly the rupture of an atherosclerotic plaque.
So plaque rupture is key here.
Yes, the formation of an arterial thrombus is a rapid and sequential process. First, platelets adhere to the damaged vessel wall. Think of them like tiny sensors that immediately detect a break. Then, more platelets are recruited to the site, forming an initial plug. And finally, thrombin is activated, which then converts fibrinogen into fibrin, creating a mesh that solidifies and stabilizes the entire clot. This rapid, localized response is critical.
And it's worth noting that our understanding of platelets has really broadened beyond just simple clotting, hasn't it? They're no longer just seen as tiny blood cells that plug holes. Their roles extend far beyond that.
Exactly. The field of platelet biology has exploded in recent years. Their role is now evolving to include complex functions in immunity, cancer metastasis, wound healing, and inflammation. They're far more sophisticated than we initially understood.
Wow, immunity metastasis. Quite a range.
It is. And despite declining rates in the U.S. for some arterial events due to better prevention and treatment, arterial thrombosis remains a major cause of morbidity and mortality worldwide. To reiterate the profound impact, heart disease, often driven by arterial thrombosis, accounts for about 1 in 4 deaths in the U.S., and we continue to see hundreds of thousands of new and recurrent myocardial infarctions and ischemic strokes annually. It's a global health priority.
So let's get into the star of the show for arterial thrombosis. The platelet itself. It's an amazing little cell, especially given that it does so much without a nucleus. It's truly a master of adaptation, packed with everything it needs.
It truly is a marvel of cellular engineering. Platelets are these disc-shaped, very small enucleate cells, meaning they lack a nucleus. They range from about 1 to 5 micrometers in diameter, so, tiny.
Really tiny.
They circulate in the blood at concentrations of 200,000 to 400,000 per microliter, and they have a relatively short lifespan of 7 to 10 days before they're cleared. Because they lack a nucleus, they cannot synthesize new proteins through gene transcription, unlike most other cells. Instead, they rely entirely on pre-synthesized molecules stored in their specialized granules and membrane compartments.
So they're like pre-packed toolkits.
Exactly. Pre-programmed, if you will, with a finely tuned arsenal of tools and signaling molecules ready to respond instantly when needed.
And where do these little powerhouses come from, given their unique structure?
They're derived from megakaryocytes, which are exceptionally large, polyploid hematopoietic cells found primarily in the bone marrow. A thrombopoietin, or TPO, is the primary hormone that regulates their formation and maturation.
Megakaryocytes, giant cells making tiny platelets.
Pretty much. The precise mechanism of how megakaryocytes release platelets is still being elucidated, but it's believed to involve the formation of long, branching structures called proplatelets, pseudopod-like extensions from which individual platelets bud off and are released into the bloodstream. What's also fascinating is that young, newly released platelets, which tend to be larger, may even continue to divide and mature further after they're released into the circulation, constantly replenishing our supply.
And their arsenal, those granules you mentioned, are packed with a wide variety of mediators that allow them to perform so many functions. Can you elaborate on the types and their contents?
Certainly. Platelet granules are synthesized within the megakaryocytes before the platelets are even released, ensuring they are fully loaded upon activation. There are 2 major types, each with distinct roles: alpha granules and dense granules.
Alpha and dense, okay.
Alpha granules are larger and more numerous, containing a wide array of soluble coagulation proteins like factor V and factor XI, adhesion molecules such as von Willebrand factor and fibronectin, various growth factors like platelet-derived growth factor, PDGF, integrins, and a host of cytokines and inflammatory mediators. They play a significant role in promoting clot stability, wound healing, and inflammatory responses.
So alpha granules are, for the bigger picture, the structure and healing.
Kind of, yeah. Dense granules, on the other hand, are smaller and fewer in number, but they contain high concentrations of potent small molecules. These include adenosine diphosphate, or ADP, serotonin, a vasoconstrictor, calcium, and polyphosphate. These contents are crucial for rapid initial platelet activation and aggregation, essentially sending out immediate come-here signals to other platelets and influencing blood vessel tone.
Dense granules are the emergency signals then.
That's a good way to put it. You can think of alpha granules as storing the long-term structural and healing tools, while dense granules are packed with the quick-release emergency signals.
Now let's break down the crucial first step in arterial clot formation: platelet adhesion. This is where the platelets first stick to a damaged vessel wall.
Hmm.
It sounds simple, but it's incredibly complex.
It's anything but simple. It's a marvel of molecular recognition. When a blood vessel is damaged, for example, when an atherosclerotic plaque ruptures, it exposes highly reactive subendothelial components that are normally hidden from the bloodstream. Key players here include collagen, which is a major structural protein, and von Willebrand factor, VWF, a large sticky protein, along with fibronectin, vitronectin, and thrombospondin. These exposed components are the immediate triggers for platelet reactivity.
So the damaged wall exposes these sticky proteins.
Right. The precise hemostatic response, meaning how strongly and quickly platelets react, can vary depending on the extent of the damage, the specific proteins exposed at the site, and crucially, the blood flow conditions, especially the shear forces at that particular site. Arterial flow is fast.
And how do platelets, being these nucleate little cells, recognize these exposed components? Do they have specific antennae or sensors on their surface?
Yes, you can absolutely think of them as having highly specialized antennae or receptors. Certain proteins expressed on the platelet surface specifically regulate their adhesion to collagen, particularly under the high flow, high shear conditions found in arteries. These include glycoprotein, GPV, GPVI, and integrin ABA1. But the platelet GPI-IXV complex adhesive receptor is truly central to both initial platelet adhesion and initiating a rapid wave of platelet activation.
GPI by XV, that sounds important.
It is. This complex acts like a grappling hook. When vessel wall damage exposes subendothelial von Willebrand factor, the GPI-IXV complex rapidly binds to it. This binding causes platelets to tether and roll along the damaged surface, slowing them down so they can then firmly adhere.
So it's not just about sticking. That initial binding also kicks off a signaling cascade within the platelet, correct? It's almost like a switch being flipped.
Exactly. The engagement of the GTI-IXV complex with its ligand, VWF, is far more than just a physical attachment. It induces a rapid series of internal signaling pathways within the platelet. That initial message essentially tells other crucial parts of the platelet to get ready for action. This activation promotes a vital calcium-dependent conformational change in another critical platelet surface receptor, the GPIAB integrin.
GPIB, okay, another key player.
A very key player. This transformation is absolutely vital for the next stage of clot formation. It changes the GPI by EA receptor from an inactive, low-affinity state, think of it as a closed, weak hand, to an active, high-affinity receptor for fibrinogen. It's now an open, super sticky hand, primed and ready for the next big step, aggregation.
Moving from sticking to changing shape, let's talk about platelet activation. This is when the platelet truly transforms from its dormant state into a dynamic responsive cell ready to play its full part in forming the clot.
Platelet activation is a finely orchestrated process, tightly controlled by a diverse array of surface receptors, each regulating distinct cellular functions. These receptors are stimulated by a wide range of agonists, meaning signaling molecules like ADP or thrombin and adhesive proteins, which collectively lead to varying degrees of activation.
So different signals can cause different levels of activation.
Exactly. Generally speaking, stimulating these platelet receptors triggers two main processes simultaneously. First, there's the activation of internal signaling pathways that further drive platelet activation and thrombus formation, essentially amplifying the initial signal. Second, there are critical interactions with other vascular cells like endothelial cells, neutrophils, and mononuclear cells, often through non-thrombotic receptors linking platelets directly to inflammation and immunity.
What are some of the most important receptor families involved in this complex activation process?
The 7-transmembrane receptor family is the primary and most important agonist-stimulated family on platelets. Within this vast family, several critical receptors exist, including those for ADP, prostaglandins, lipids, and chemokines. But among the most prominent and clinically significant are the thrombin receptors, specifically PAR1, PR2, and PR4. Thrombin is one of the most potent activators of platelets.
Thrombin receptors have a fascinating, almost self-activating way of working, don't they? It's not just a simple molecule binding to a receptor.
No, it's quite unique and highly efficient. PAR activation involves a specific enzymatic cleavage of the N-terminus of the receptor by thrombin itself. This newly cleaved N-terminus then acts as a tethered ligand, meaning it folds back and binds to the activated receptor, effectively self-activating it.
Wow. Thrombin cuts the receptor, and the cut piece activates it. Clever.
It's a very clever and potent mechanism that ensures rapid and strong platelet activation in the presence of thrombin. Then there are the ADP receptors, which are purinergic receptors. The key ones here are P2X1, P2Y1, and P2Y12. These are responsible for ADP-induced signaling, which is a major pathway for platelet aggregation. It's crucial to understand that activation of both the P2Y12 and P2Y1 receptors is essential for full, stable ADP-induced platelet aggregation to occur. If one is blocked, the aggregation is impaired.
And this is where we see a direct, very important clinical link, isn't it, in terms of medications?
Precisely. The thienopyridine derivatives, such as clopidogrel and prasugrel, are widely used clinically to inhibit ADP-induced platelet aggregation. They specifically target and block the P2Y12 receptor, effectively preventing one of the crucial signals for platelets to clump together.
So drugs like Plavix work right here.
Exactly. Plavix is clopidogrel. They reduce the risk of arterial clots like those that cause heart attacks and strokes. This direct pharmacological intervention highlights the importance of understanding these specific receptor pathways.
So once platelets are activated and changing shape, the next crucial step is aggregation, where they all clump together to solidify the initial plug into a stable clot.
That's right. Platelet activation sets off a rapid series of signal transduction events inside the cell. This involves the activation of various enzymes, including tyrosine kinases, serine-threonine kinases, and lipid kinases, all working in a complex network to amplify the initial signal. At the very heart of this aggregation process is the major platelet integrin, GPI-B-agrin.
Back to GPI-B.
Yes. What's truly unique and critical about this integrin is that it's only expressed on platelets, making it a highly specific target. In an unstimulated platelet, GPI-B is maintained in an inactive conformation. Think of it as a folded, low-affinity state for fibrinogen, meaning it doesn't readily bind to it.
But once that platelet gets stimulated by thrombin, or ECP, that's when GPI-B changes, right?
Exactly. Upon stimulation, a calcium-sensitive conformational change occurs in the extracellular domain of GPI-B. This profound structural change enables it to bind soluble plasma fibrinogen with high affinity. And it's this interaction, the activated GPI-B on one platelet binding to fibrinogen, which then also binds to an activated GPI-B on an adjacent platelet, that forms the intercellular connection.
So fibrinogen is the bridge between platelets.
Precisely. Imagine fibrinogen acting as a molecular bridge, linking multiple activated platelets together, leading to the formation of a stable macroscopic platelet aggregate. This is the physical formation of the platelet plug.
And there's a fascinating bidirectional signaling happening here, correct? It's not just a one-way street of activation.
Yes, it's a sophisticated feedback loop that ensures the clot is not only formed but also stabilized. There's inside-out signaling, which is a complex network of intracellular events that ultimately leads to the high-affinity binding of fibrinogen. This is the platelet receiving a signal and then changing its surface to become sticky.
Inside out. Signal leads to stickiness.
Right, but then immediately after fibrinogen binds to GPI-B, outside-in signaling occurs. This triggers additional intracellular signaling that further stabilizes the platelet aggregate. This second wave of signaling transforms the aggregate from a reversible state, where it could potentially bend apart, to an irreversible process, effectively locking it in place and ensuring a strong, stable thrombus formation.
Outside in. Binding locks it down. Makes sense.
It's this intricate interplay that makes the platelet such an effective and dynamic player in clotting.
Now let's step back a bit and talk about something truly fascinating that expands our understanding of platelets beyond just their role in clotting. They actually play a significant role in inflammation, infection, and immunity, connecting thrombosis to much broader physiological processes. It seems like these tiny cells are involved in almost everything.
This is an increasingly recognized and incredibly important area of platelet biology. We now know that inflammation, for example, plays a crucial role during the acute thrombotic phase of conditions like acute coronary syndromes and other vascular occlusive events.
So inflammation and clotting are linked.
Absolutely. There's a direct link. We even see how acute upper respiratory infections are associated with a higher risk of myocardial infarction and thrombotic stroke. It's not just about plaque rupture. There's an inflammatory component that primes the system for clotting.
So it's not just about what the platelets do to each other, but how they interact with other cells, particularly immune cells. This sounds like they're communication hubs.
Exactly. In patients experiencing acute coronary syndromes, you observe significantly increased interactions not only between platelets themselves, forming what we call homotypic aggregates.
Platelet to platelet.
Right, but also, crucially, increased interactions between platelets and leukocytes, forming heterotypic aggregates.
Platelet to immune cell.
Yes. These mixed aggregates are detectable in circulating blood and are a key indicator of systemic inflammation. These heterotypic aggregates form when platelets become activated, often directly by pathogens, but also by inflammatory signals, and then adhere to circulating leukocytes, such as monocytes and neutrophils, as part of their contribution to the immune process.
So they're calling in the immune troops.
It's a way for platelets to alert and recruit other immune cells to a site of potential danger or injury.
How does that adherence happen at a molecular level? What are the specific molecules involved in this intercell communication?
It's highly specific. Activated platelets bind to leukocytes primarily via a molecule called p-selectin, which is rapidly translocated to the surface of activated platelets from their alpha granules.
P-selectin from the alpha granules.
Okay. This p-selectin then binds to a specific receptor on leukocytes called p-selectin lipoprotein ligand 1, or PSGL1. This initial association, this handshake between platelet and leukocyte, has profound effects. It leads to increased expression of another adhesion molecule, CD11b-CD18, also known as MAC1, on leukocytes. This amplifies the immune response, but it can also support further interactions with platelets, partly through bivalent fibrinogen acting as a bridge, linking MAC1 on the leukocyte with the platelet surface receptor, GPI-beta.
Wow, so that handshake leads to more connections.
Exactly. Furthermore, platelet surface p-selectin also induces the expression of tissue factor on monocytes. Remember tissue factor?
Yes, the initiator of the coagulation cascade.
Right, so this interaction directly promotes fibrin formation, clearly linking inflammation to the coagulation cascade and thrombosis.
And there's another important immunomodulator, CD40 ligand, that also forms a crucial link between thrombosis and inflammation, correct?
That's absolutely correct. CD40 ligand, also known as CD40L or CD154, is a trimeric transmembrane protein belonging to the tumor necrosis factor family. Along with its receptor CD40, it's a critical contributor to the inflammatory response and is expressed on various immune cells. In platelets, CD40 ligand is stored in alpha granules and is rapidly translocated to the platelet surface after stimulation. It is also found to be significantly upregulated in newly formed thrombi, highlighting its role in the thrombotic process.
So it shows up in the clot itself.
Yes. What's more, CD40 ligand can be cleaved from the platelet surface to generate a soluble fragment, soluble CD40 ligand, which can circulate in the blood and contribute to systemic inflammation and vascular dysfunction. So platelets are not just passive participants, they are active modulators of the inflammatory environment.
And it seems platelets are also on the front lines against infection, too, acting as part of our immune defense.
Absolutely. The links among platelets, infection, immunity, and inflammation have been firmly established and are a major area of research. We know that both bacterial and viral infections are often associated with a transient but significant increase in the risk of acute thrombotic events like myocardial infarction and stroke.
So getting sick can increase your clot risk.
It can. Consider sepsis, a life-threatening condition caused by the body's overwhelming response to infection. Platelets contribute significantly to the complex pathophysiology and, unfortunately, the high mortality rates seen in sepsis, often leading to widespread microvascular clotting.
And they do this through specific receptors, almost like they have their own immune detection system.
Yes, precisely. The expression, functionality, and signaling pathways of toll-like receptors, or TLRs, have been well established in platelets. TLRs are a class of proteins that play a key role in the innate immune system, recognizing conserved pathogen-associated molecular patterns. Platelets have been shown to express functional TLR2, TLR3, and TLR4. Stimulation of platelet TLR2, TLR3, and TLR4 directly and indirectly activates the platelet's thrombotic and inflammatory responses.
So they can sense bacteria and viruses.
Exactly. For instance, live bacteria can induce a robust pro-inflammatory response in platelets in a TLR2-dependent manner, suggesting a direct mechanism by which specific bacteria and their components can activate platelet-dependent thrombosis. And it's not just bacteria. A wide range of viruses, including SARS-CoV-2, which causes COVID-19, HIV, hepatitis C virus, and dengue virus, are known to cause elevated levels of thrombosis in infected individuals. Platelets have been shown to regulate immune responses to these viruses via TLR7 and TLR8.
TLR7 and 8 for viruses.
Yes, demonstrating their direct involvement in antiviral immunity and their capacity to link infection to thrombotic risk. It's a beautifully complex, integrated system where platelets are truly at the crossroads of hemostasis, immunity, and inflammation.
Moving from the microscopic to the macroscopic, let's talk about the broad risk factors for arterial thrombosis, and then, crucially, delve into the emerging and often debated role of genetics. This is where personalized medicine potentially comes into play.
Classically, and still most profoundly, the cardiovascular risk factors implicated in arterial thrombosis are hypertension, high levels of low-density lipoprotein cholesterol, the bad cholesterol, and cigarette smoking.
The big three.
Yep. These factors contribute to the development of atherosclerosis, the hardening and narrowing of arteries, which is the underlying substrate for most arterial thrombotic events. However, the list of contributors extends to other significant factors like diabetes mellitus, which damages blood vessels, increasing age, pregnancy, and even certain chemotherapeutic agents, which can directly affect vessel walls or clotting factors.
Chemo can increase risk.
Interesting.
It can. Reproductive factors are also relevant, though often overlooked. A history of stillbirth and the loss of multiple pregnancies may increase the long-term risk of ischemic stroke and myocardial infarction, as can hormonal replacement therapy, highlighting the interplay of hormones and the clotting system.
And autoimmune conditions can play a role here too, bridging different aspects of health, correct?
Yes, absolutely. Systemic lupus erythematosus, or SLE, and rheumatoid arthritis, both chronic inflammatory autoimmune diseases, are now well-recognized risks for thrombosis. In particular, SLE carries a significant risk and is particularly relevant in the pediatric population for thrombotic events. Furthermore, the antiphospholipid syndrome is a widely recognized and clinically important autoimmune condition that carries a high prothrombotic risk for both arterial and venous thrombosis.
Antiphospholipid syndrome, high risk for both.
Yes. In this syndrome, the immune system produces antibodies that attack phospholipids, which are components of cell membranes, leading to a tendency to form blood clots. So the body's own immune response can directly contribute to clotting risk.
Now on to genetics. Our sources mentioned some studies associating arterial thrombosis with genetic variants, but with a big caveat, suggesting it's not as straightforward as some might hope.
That's a crucial point for a truly deep understanding. While some studies have indeed associated arterial thrombosis with genetic variants in various components, for instance, in platelet receptors like P3 and DANA2, the PLA2 polymorphism, Fe gamma RIEA, GPFE, GPI, and the thrombin receptor, PAR1, as well as in redox enzymes like plasma glutathione peroxidase, endothelial nitric oxide synthase, and peroxinase, and even homocysteine-related genes like cystathionine synthase and MTHFR. It's critical to emphasize that these associations are generally weak.
Weak associations.
Okay. And, perhaps more importantly, often not consistently confirmed in larger, more robust contemporary studies. This means we're not quite at the point where we can confidently predict an individual's arterial thrombosis risk based solely on these specific genetic markers.
So no simple genetic test for heart attack risk yet based on these.
Not reliably based on these specific ones, no. There's still a lot of research needed to tease out truly impactful genetic predispositions for arterial disease.
So we're not quite at the point where we can just look at your genes and tell you your arterial thrombosis risk with high certainty, at least from these factors alone. What about genome-wide association studies, or GWAS, which cast a wider net? Have they shed more light?
GWAs are a different approach. They scan the entire genome for common genetic variations that are associated with a particular disease or trait. In the context of platelet function, GOAs have been used to study more general platelet characteristics, like platelet count and mean platelet volume, identifying signals in non-coding regions of the DNA. Interestingly, one of these identified regions, located at 12q24, is also a known risk locus for coronary artery disease.
So a link between general platelet traits and artery disease risk.
Exactly. This suggests that while individual platelet receptor gene variations might have weak direct links, there could be broader genetic influences on platelet biology that subtly contribute to arterial disease risk, even if indirectly.
But the most significant area of genetic variability in platelet function, and perhaps the most clinically relevant for our listeners, seems to be pharmacogenetics, how our individual genetic makeup influences our response to drugs. This truly opens the door to personalized medicine, doesn't it?
Absolutely. Pharmacogenetics is a rapidly evolving field, and its focus on the inter-individual variability and drug response based on our unique genetic determinants is incredibly promising. This field has been heavily driven by the wide variation in how different individuals respond to antithrombotic drugs, and the pressing need to understand why some patients benefit greatly while others have inadequate responses or experience side effects.
The concept of aspirin resistance comes to mind here, a term often heard. How does genetics play into that?
Indeed, the concept of aspirin resistance refers to patients who show an inadequate or suboptimal antiplatelet response to aspirin's inhibitory effects. It's true that heritable factors, meaning genetic variations, do contribute to this observed variability in response.
Or genetics is involved somehow.
It contributes, yes. However, and this is a crucial nuance for anyone aspiring to an elite understanding, it's very important to note that ex vivo tests, meaning tests done in a lab, outside the body of residual platelet responsiveness after aspirin administration, have not provided firm evidence for a direct pharmacogenetic interaction between aspirin and COX-1, the enzyme it targets, or other relevant platelet receptors.
So the lab tests don't confirm a direct gene-drug interaction for aspirin.
Not firmly, no. This means that while genetic factors might play a subtle role in overall platelet reactivity, there is currently no clinical indication for genotyping to optimize aspirin's antiplatelet efficiency.
Okay, so no routine genetic testing for aspirin effectiveness.
Correct. For now, clinicians don't routinely use genetic tests to decide aspirin dosage or effectiveness. The term aspirin resistance might still be used clinically, but the genetic link isn't straightforward enough for routine application.
What about other common antiplatelet drugs like clopidogrel, which is so widely prescribed? Does genetics have a clear impact there?
For clopidogrel, a P2Y12 receptor inhibitor widely used after heart attacks or stent placements, the data do suggest that genetics can significantly affect the drug's responsiveness and overall clinical utility.
Ah, so it does matter for clopidogrel.
It appears so. Interestingly, the responsible genetic variant doesn't appear to be in the P2Y12 receptor itself, which clopidogrel targets, but rather in the cytochrome P450 or CYP enzyme, specifically CYP2C19, CYP3A4, and CYP3A5.
The liver enzymes that activate the drug.
Precisely. These are crucial liver enzymes required for clopidogrel to be metabolized into its active form. Without these enzymes functioning optimally, the drug simply isn't activated effectively.
So certain genetic variations in these enzymes mean the drug isn't activated as effectively, leading to a weaker antiplatelet effect.
Exactly. The genes encoding these CYP-dependent oxidative steps are known to be polymorphic, meaning they have common genetic variations in the population. Carriers of specific alleles or forms of a CYP2C19 and CYP3A4 loci have consistently shown increased platelet aggregability even while on clopidogrel, indicating a diminished drug effect.
So they clot more easily even on the drug.
Right. For instance, the CYP2C192 allele is particularly well studied and is strongly linked to a significant loss of platelet function in some patients. This is a clinically relevant observation, as these patients might be at higher risk for recurrent thrombotic events while on standard clopidogrel therapy.
That seems really important clinically.
It is, however, it's also important to understand the limitations. While this specific polymorphism is the strongest individual variable affecting clopidogrel's pharmacokinetics and antiplatelet response, it only accounts for about 5% to 12% of the overall variability in ADP-induced platelet aggregation observed in patients on clopidogrel.
Only 5–12%, so other factors are still huge.
Exactly. So there are other factors at play. For other P2Y12 inhibitors, such as prasugrel or ticagrelor, which have different activation pathways or are active as administered, genetic variables do not appear to contribute significantly to their clinical outcomes, highlighting the drug-specific nature of pharmacogenetics.
Let's shift our focus now to venous thrombosis. This side of the clotting story is dominated not by platelets, but primarily by the coagulation cascade. It includes the formidable duo of deep vein thrombosis, DVT, and pulmonary embolism, PE, often referred to collectively as a silent killer due to their insidious nature and potentially fatal consequences.
This is indeed a critical area of medicine. The primary forms of venous thrombosis are deep vein thrombosis, or DVT, which typically occurs in the deep veins of the extremities, most commonly the legs. The most dangerous complication, however, is when a piece of that DVT breaks off and travels through the bloodstream to the lungs, causing a pulmonary embolism, or PE.
DVT leading to PE, got it.
Together, these are known as venous thromboembolic disease, or VTE. While most events occur as PE or DVT of the lower extremities, it's important to note that up to 10% of VTE events can occur in other vascular locations, such as the upper extremities or abdominal veins.
And the incidence and mortality figures here are equally concerning, highlighting how widespread and dangerous this condition truly is.
They are profoundly concerning. It's estimated that DVT or PE occurs in approximately 1 to 2 individuals per 1,000 in the general population each year.
1 to 2 per 1,000 per year.
Yes, leading to anywhere from 300,000 to 600,000 new VTE cases annually in the U.S. And tragically, between 60,000 and 80,000 deaths are directly attributed to DVT or PE each year.
60 to 80,000 deaths, that's huge.
It is. The clinical outcomes for patients who develop VTE can be quite severe. Up to 30% of patients die within 30 days of a new case, often due to the PE itself. A particularly chilling statistic is that 1/5 of those with PE suffer sudden death.
Sudden deaths from PE, terrifying.
Furthermore, even for those who survive, the risk of recurrence is high, with 30% of patients developing recurrent VTE within 10 years. Data from the ERIC study, a large population-based study, reported a 9% 28-day fatality rate from DVT and a 15% fatality rate from PE. In patients with cancer who are at a significantly higher risk for VTE, the fatality rate for PE is even higher, at 25%. These figures underscore the lethal potential of venous thrombosis.
Do we see particular age or gender trends with venous thrombosis, or is it truly something that can affect anyone?
It's important to stress that VTE can affect women and men of all ages, races, and ethnicities. However, there are clear trends. The mean incidence of a first DVT in the general population is around 5 per 10,000 person years. While the overall incidence is similar in males and females when adjusted for specific reproductive factors like pregnancy or birth control use, the risk dramatically increases with age.
Age is a big factor then.
A major factor. For example, it jumps from a relatively low 2 to 3 per 10,000 person years at 30 to 49 years of age, to a staggering 20 per 10,000 person years at 70 to 79 years of age. This highlights age as a major non-modifiable risk factor. Broadly speaking, venous thrombosis results from a complex interplay of both heritable or genetic and acquired causes.
Now let's unpack the engine behind venous thrombosis, the coagulation cascade. This is a complex symphony of enzymes working in concert, a true biological marvel in its efficiency.
It truly is a remarkable and intricate system. Coagulation, in this context, is defined as the formation of fibrin, the structural backbone of a blood clot, through a series of linked enzymatic reactions. In this cascade, it's like a molecular relay race. Each reaction product, which is an active enzyme, converts a subsequent inactive precursor molecule called a zymogen into its active serine protease form.
Zymogen to active enzyme, like flipping switches.
Exactly. This coordinated sequence is a fundamental mechanism for regulating hemostasis, ensuring rapid and localized clot formation. What's central to its function, and so ingenious, is the principle of amplification.
Amplification, meaning a small start leads to a big result.
Precisely. A very small initial stimulus at the site of injury can lead to vastly greater, exponentially increasing quantities of activated enzymes and ultimately a massive amount of fibrin. This rapid amplification is what allows for quick, robust clot formation to prevent hemorrhage.
And newer research is broadening our understanding beyond the classic cascade, right? It's not just about these enzymes anymore.
Yes. While the classic coagulation cascade provides a foundational understanding, recent research has significantly expanded our view, highlighting contributions from previously underappreciated players. Beyond the well-known risk factors related to hypercoagulopathy, blood stasis, and vascular dysfunction, newer insights have highlighted the crucial roles of procoagulant microparticles, tiny fragments shed from cells that carry clotting factors.
Microparticles, like little clotting messengers.
Kind of, yeah. Also, inflammatory cells like neutrophils and monocytes, microvesicles, and even the specific structure and stability of the fibrin itself in promoting and regulating clot formation. The cascade is primarily initiated when there's vascular injury, which exposes tissue factor, or TF, to blood components. TF acts as a key trigger. Interestingly, TF isn't just found on damaged vessel walls. It can also be found in blood-borne cell-derived microparticles, and under certain pathophysiologic conditions on the surface of activated leukocytes or platelets, providing alternative routes for coagulation initiation.
So TS can come from different places. Okay,
Sure.
so let's walk through the key steps of this cascade, almost like a play-by-play. It's a complex dance, but if we break it down, it helps us understand its logic.
Certainly. Let's imagine this as a series of dominoes where one activated factor triggers the next. It begins when plasma factor 7, or FVII, a circulating inactive protein, binds to and is activated by tissue factor, TF, at the site of vessel damage, forming FVII, the active form. This FVII-TF complex is the primary initiator. It then activates factor X, or FX, to its active form, FXX.
TF activates 7, which activates X. Got it.
Now, importantly, there's an alternative or parallel pathway.
Okay.
The FVIA-TF complex can also initially convert factor IX or FIX to FIXA, which then efficiently activates FX in conjunction with its cofactor factor VIII or FVIA. This alternative pathway amplifies the FXA generation.
So multiple paths can lead to factor X activation, essentially ensuring the process is robust. What happens once factor X is active?
Once FXA is active, it forms a crucial complex with its cofactor, factor ROB. This complex is called the prothrombinase complex, and it's a powerhouse. Its main job is to convert prothrombin, another inactive protein, into thrombin.
Prothrombinase makes thrombin.
Right. And this is where the magic, or rather the true clot-forming power, happens. Thrombin is the master enzyme of coagulation. It then converts soluble plasma fibrinogen, which is freely circulating in your blood, into insoluble fibrin.
Thrombin makes fibrin the clot mesh.
Exactly. Fibrin is the actual structural component that forms the meshwork of the clot or thrombus. Thrombin doesn't stop there. It also activates factor 13 to SVI. FXA is a transglutaminase that covalently cross-links and stabilizes the fibrin clot, making it much stronger and more resilient, preventing it from breaking down prematurely.
So factor 13 locks the fibrin together.
Precisely, makes it stable.
And the physical structure of that fibrin also matters, not just its presence, doesn't it?
It absolutely does. The overall formation and stability of thrombi are significantly affected by mechanisms governing fibrin structure. For example, specific genetic variants of fibrinogen itself can subtly alter how fibrin forms, its strength, and its overall architecture, which can impact how easily a clot forms or breaks down. But it's vital to remember that the body isn't without its own checks and balances. Alongside this procoagulant cascade, several crucial antithrombotic factors also constantly regulate coagulation.
The brakes on the system.
Exactly. These factors work to limit thrombin production and prevent the perpetuation of coagulation and thrombus formation beyond what's necessary for normal conditions. They are the body's natural brakes.
What are some of these crucial braking mechanisms that keep the cascade in check?
Key antithrombotic factors include antithrombin, a powerful inhibitor of thrombin, and other activated clotting factors like FXA. Then there's tissue factor pathway inhibitor, or TFPI, which directly inhibits the initial TF-FVII complex.
Antithrombin and TFPI.
Heparin cofactor 2 is another thrombin inhibitor. And finally, the protein C protein S system, which is activated by thrombin bound to thrombomodulin on the endothelial cell surface. Activated protein C, with protein S as its cofactor, inactivates factor VA and factor LA, essentially shutting down the amplification loop.
Protein C and S shut down the amplification.
Right. Typically, once a clot has formed and occluded the damaged site, preventing further bleeding, the anticoagulant reactions governed by the normal, undamaged endothelium surrounding the clot become pivotal. These factors help limit the extent of this hemostatically protective clot, preventing it from growing beyond its necessary boundaries and causing harm.
Given how serious and prevalent venous thrombosis can be, what are the primary risk factors for developing it? It seems to be a complex web of predispositions.
It truly is a multifaceted problem with a complex interplay of factors, and it's important to stress that VTE risk applies to women and men of all ages, races, and ethnicities. The traditional overarching categories of risk factors are often summarized as Virchow's triad: hypercoagulability, meaning an increased tendency of the blood to clot, immobilization, which leads to sluggish blood flow, and venous stasis, also referring to slow blood flow, often due to prolonged immobility.
Virchow's triad: hypercoagulability, stasis, and I miss one. Oh, vessel wall injury, though less common in veins initially.
Right, endothelial dysfunction or injury is the third part, though stasis and hypercoagulability are often key drivers in venous thrombosis. Independent predictors that also increase the risk for recurrence of VTE include increasing age, obesity, having a malignant neoplasm or cancer, and acute extremity paresis, such as weakness or paralysis in a limb, which would also lead to stasis.
It's a confluence of factors, and genetics plays a surprising significant role here too, correct?
Yes. It's estimated that 5% to 8% of the U.S. population has at least one genetic risk factor known to predispose them to venous thrombosis.
5 to 8%. That's not insignificant.
Not at all. And very often, multiple risk factors, both genetic and acquired, are present in a single individual, creating a cumulative risk that dramatically increases their likelihood of developing a VTE. This synergistic effect makes understanding individual risk profiles complex, but crucial.
What are some of the most significant high-risk scenarios that clinicians are particularly vigilant about?
Major surgeries are a prime example. Orthopedic surgeries, especially hip and knee replacements, abdominal surgeries, or neurologic surgeries, significantly elevate VTE risk due to a combination of surgical trauma to veins, immobilization during recovery, and activation of clotting factors.
Surgery is a big one.
A very big one. Cancer patients, for instance, have approximately a four-fold increased VTE risk compared to the general population. This is due to various mechanisms, including tumor-associated procoagulant factors and systemic inflammation. Community or hospital-acquired infections also significantly increase VTE risk, often due to the systemic inflammatory response. And more recently, we've learned that nearly 20% of hospitalized COVID-19 patients exhibit significant coagulation abnormalities.
Right, the COVID clotting connection was huge news.
Exactly. An increased risk of PE, DVT, and even peripheral thrombotic events, highlighting the profound prothrombotic state induced by severe viral infections.
Now, what about moderate risk factors that might not be as immediately life-threatening but still contribute to a significant population burden?
Moderate risk is promoted by conditions that lead to prolonged bed rest, again emphasizing the role of venous stasis. Certain types of cancer, even those not undergoing surgery, also contribute. Pregnancy and the postpartum period carry a relative risk of 4.3 for VTE, with an overall incidence of nearly 200 cases per 100,000 woman years, highlighting the hormonal and physiological changes that promote clotting during this time.
Pregnancy is a known risk period.
Yes. Hormone replacement therapy or oral contraceptive use also fall into this category due to their impact on clotting factors. Other sedentary conditions like long-distance plane travel can also increase risk. It's been reported that the risk of a venous thromboembolic event doubles after air travel lasting 4 hours.
The 4-hour flight rule, sort of?
Kind of, though the absolute risk remains low at about 1 in 6,000. Finally, myeloproliferative disorders like polycythemia vera conditions where the bone marrow produces too many blood cells are also associated with a moderate but definite risk of VTE.
Speaking of genetics, let's dive deeper into the inherited predispositions for venous thrombosis. What kinds of genetic abnormalities are we looking at here, and how do they impact an individual's risk?
Genetic variants represent less common but undeniably significant causes of venous thrombosis. These abnormalities can broadly be categorized into two types: loss-of-function mutations of endogenous anticoagulants.
Meaning the body's natural brakes are weaker?
Right. The body's natural clot-inhibiting mechanisms aren't working as efficiently as they should, or, conversely, gain-of-function mutations of procoagulant proteins.
Meaning the accelerators are stuck on.
Exactly. The clot-promoting factors are overly active or resistant to natural regulation. It's absolutely. Heterozygous antithrombin deficiency is one such example. Individuals with one copy of this mutated gene have reduced levels of antithrombin, a key natural anticoagulant, significantly increasing their VTE risk. Another high-impact mutation is homozygosity of the factor V Leiden mutation, meaning inheriting two copies of this specific gene variant. This leads to a substantial increase in the risk of venous thrombosis.
2 copies of factor V Leiden is high risk.
Very high risk. While homozygous protein C, or protein S deficiencies, are incredibly rare and can lead to severe, often fatal conditions in newborns like purpura fulminans, heterozygous deficiencies inheriting one copy of the mutated gene are associated with a moderate but definite risk of thrombosis in adults.
Factor V Leiden comes up a lot when discussing venous thrombosis. It seems to be one of the more common genetic predispositions. Can you explain in a bit more detail what it is and why it's so impactful?
Factor V Leiden is indeed the most common inherited cause of thrombophilia, affecting about 5% of Caucasian populations. It's a single-point mutation in the factor V gene, which is located on chromosome 1. This seemingly small change results in a form of factor V that is resistant to activated protein C, or APC.
Resistant to the brakes again.
Exactly. Normally, APC is a natural anticoagulant that acts by degrading factor V, which is a crucial cofactor in the coagulation cascade. But when you have factor V Leiden, the mutated factor V cannot be efficiently inactivated by APC. This means that factor V remains active for longer, leading to persistent thrombin generation and a prothrombotic state. It's like the body's natural brake on clotting isn't working effectively, increasing the tendency to form venous clots.
And what about more subtle genetic influences beyond these high-impact mutations? Are there other genetic factors that might mildly increase risk?
Yes, mildly increased risk of VTE has also been attributed to chronically elevated elevated levels of certain procoagulant factors, such as factor 8, factor 9X, or factor 11, or to chronically low levels of tissue factor pathway inhibitor. Furthermore, elevated levels of homocysteine in the blood, a condition known as hyperhomocystinemia, as well as polymorphisms, or common genetic variations of the methylene tetrahydrofolate reductase, or MTHFR, enzyme, have been shown to be independent risk factors for both venous thrombosis and arterial vascular disease.
Homocysteine and MTHFR link both arterial and venous.
Interesting. Yes, suggesting a shared underlying pathway. However, it's always important to add a note of caution here. As for many genetic variants initially described, their associations with thromboembolism are continually being questioned or refined in larger, more contemporary population studies. The picture is constantly evolving.
So the science is still developing on some of these weaker links.
Very much so.
Finally, in this section, let's discuss fibrinolysis, the body's natural clot-busting system, and its critical relationship to thrombosis. It's not just about forming clots, but also about knowing when to break them down.
Fibrinolysis is precisely that. The elegant and essential process of breaking down fibrin clots once they are no longer needed or when they form inappropriately. And specific abnormalities in this crucial system can definitely lead to enhanced thrombosis, as the body's ability to clear clots is impaired.
So if clot busting is weak, clots stick around longer.
Exactly. For example, elevated levels of tissue plasminogen activator, TPA, which normally initiates fibrinolysis, or, more commonly, elevated levels of plasminogen activator inhibitor type 1, PAI1, which inhibits TPA, have both been associated with decreased fibrinolytic activity and, consequently, an increased risk of arterial thrombotic disease. It's a balance between initiating clot breakdown and inhibiting it.
High PAI means less clot breakdown, more risk.
Generally, yes.
Are there specific genetic variants that are known to affect this delicate fibrinolytic balance?
Yes. For instance, the 4G5G insertion-deletion polymorphism in the PAI1 gene has been associated with altered PAI1 levels and decreased fibrinolytic activity, potentially increasing thrombosis risk. Additionally, a 311 base pair ALU insertion deletion in TPA's intron 8 has been observed to be associated with enhanced thrombosis, although the consistency of this association with definitively altered function or TPA levels is still being questioned and actively researched. Another key player in fibrinolysis is thrombin activatable fibrinolysis inhibitor, or TAFI.
CoFast sounds like it inhibits fibrinolysis.
It does. TFI is a carboxypeptidase that, once activated by thrombin, modifies fibrin, making it more resistant to breakdown by plasmin. Elevated plasma TFI levels have been consistently associated with an increased risk of both DVT and cardiovascular disease, indicating that an overactive TFI can tilt the balance towards prolonged clot stability.
And how does something like metabolic syndrome, which is so prevalent, fit into this complex picture of clotting and clot breakdown?
Metabolic syndrome, a cluster of conditions that includes abdominal obesity, altered glucose and insulin metabolism, dyslipidemia, abnormal cholesterol levels, and hypertension, is indeed very prevalent globally. And it's consistently accompanied by altered fibrinolytic activity.
Metabolic syndrome messes with clot breakdown too.
Yes. This syndrome is strongly associated with atherothrombosis, the formation of clots on atherosclerotic plaques. The mechanism for this enhanced thrombosis appears to be multifaceted. It's due to both altered platelet function, making platelets more reactive, and a systemic procoagulant and hypofibrinolytic state.
So more clotting tendency and less breakdown ability.
Exactly. In simpler terms, the body of someone with metabolic syndrome is generally more prone to clotting and less efficient at breaking down those clots. It's a systemic condition that significantly tilts the balance towards unwanted clot formation.
We've covered a tremendous amount of ground today, delving into the distinct, yet sometimes overlapping, mechanisms of arterial and venous thrombosis. Now let's bring it all together by highlighting their core distinctions, their surprising similarities, and the shared risks that tie these two complex worlds together.
The differences in their formation and the resulting clot composition are indeed quite striking, and understanding these distinctions is key to understanding why they are treated differently. In arterial thrombosis, the initiation is primarily superimposed on a disrupted atherosclerotic plaque. Imagine a hardened, diseased blood vessel wall that develops a crack or rupture. When that plaque ruptures, it exposes highly thrombogenic material components that vigorously promote clotting to the flowing blood.
And that leads to a very specific type of clot, right?
Yeah.
A white thrombus.
Exactly. Due to the very high shear forces in injured arteries, the rapid turbulent flow of blood arterial thrombi are predominantly platelet-rich. Platelets are immediately recruited to the site of injury and rapidly form the bulk of the clot. Because of this platelet dominance, they often appear whitish or grayish, earning them the nickname white thrombus.
White thrombus, arterial, platelet-rich, high flow.
Correct. The result is a clot that can temporarily or permanently occlude blood flow, leading to critical events like myocardial infarctions or ischemic strokes, where oxygen supply to downstream tissue is severely compromised or cut off entirely.
How does that compare to venous thrombosis, which forms in a very different environment?
Venous thrombi rarely form at sites of obvious major vascular disruption, unlike arterial clots. They usually originate in the valve cusps of the deep veins of the calf or in muscular sinuses where blood flow is naturally slower.
Slower flow in the valve pockets.
Right. They can also develop after surgical trauma to veins or due to indwelling venous catheters where local irritation and stasis contribute. The mechanism of formation here is quite distinct. Sluggish blood flow in veins reduces oxygen supply to the avascular valve cusps, causing endothelial cells in that area to become activated and express adhesion molecules on their surface.
So it's more about the flow dynamics in the local cellular environment than a direct injury.
Precisely. Tissue factor-bearing leukocytes and microvesicles then adhere to these activated endothelial cells and induce coagulation locally, initiating the cascade we discussed. Furthermore, an interesting new area of research highlights how DNA extruded from neutrophils forms neutrophil extracellular traps, or nets.
Nets, like a spider web from neutrophils.
Kind of, yeah. These nets provide a crucial scaffold that not only binds platelets and promotes their activation and aggregation, but also directly activates factor 12, another initiator of the coagulation cascade. This local thrombus formation is further exacerbated by the reduced clearance of activated clotting factors due to impaired blood flow, a critical aspect of venous stasis. So the environment itself becomes pro-clotting.
And what about the composition of a venous clot? Does it look different from an arterial one?
Yes, quite different. Because venous thrombi form under low shear conditions, they contain relatively few platelets compared to arterial clots. Instead, they are predominantly composed of fibrin, the mesh-like protein scaffolding, and large numbers of trapped red blood cells.
So lots of fibrin and red cells, fewer platelets, makes a red thrombus.
Exactly. This gives them a distinct red appearance, hence the term red thrombus. A significant and often life-threatening complication is that if these thrombi extend from the smaller calf veins into more proximal leg veins, fragments can dislodge, travel through the right side of the heart, and then block blood flow to the lungs, producing a pulmonary embolism.
These striking differences in composition also drive vastly different treatment strategies, I imagine.
They absolutely do, and this is a critical clinical takeaway. Because arterial thrombi are so platelet predominant, strategies to attenuate their formation and growth focus mainly on antiplatelet agents, like aspirin or clopidogrel, which directly inhibit platelet function.
Antiplatelets for the white, platelet-rich clots.
Right. In contrast, venous thrombi, being rich in fibrin and red cells, are primarily targeted by anticoagulants. These drugs work by inhibiting various factors in the coagulation cascade, preventing the formation and growth of the fibrin mesh, and thus preventing new clots or the extension of existing ones.
Anticoagulants for the red, fibrin-rich clots.
Yeah.
Makes sense.
This foundational understanding of clot composition directly informs therapeutic choices.
So while their pathophysiology is distinct and leads to different treatments, there are surprising overlaps and shared risks between arterial and venous thrombosis, aren't there? It's not an entirely separate universe for each.
No, not at all. Despite the distinct pathophysiologies we've meticulously explored, there is a fascinating interplay. For instance, animal models often show a poor correlation between an individual's propensity to develop one type of thrombosis versus the other, which reinforces their distinct underlying nature. However, when we look at hypercoagulable states, these are well understood and significant contributors to venous thromboembolism. But their contribution to arterial vascular disease is much less understood. Many of the inherited thrombophilic factors we discussed earlier, like factor V Leiden, are not clinically important risk factors for arterial events like acute coronary syndromes.
So the genetic risks don't always cross over neatly.
Not always, no.
But there are common, broader risk factors that apply to both, suggesting shared vulnerabilities in the body's systems.
Absolutely. Clinically, arterial and venous thrombosis share several conventional risk factors that influence overall vascular health. These include increasing age, obesity, cigarette smoking, diabetes mellitus, arterial hypertension, hyperlipidemia, and metabolic syndrome.
The usual suspects for overall vascular health.
Pretty much. These conditions often create a pro-inflammatory and pro-thrombotic environment in the body that can affect both arterial and venous systems. Interestingly, select genetic variants, such as those of the glutathione peroxidase 3, GPF3 gene, have also been associated with both arterial and venous thrombo-occlusive disease, hinting at shared genetic susceptibilities impacting fundamental processes like oxidative stress.
And critically, both types of thrombosis can be triggered by similar inflammatory and oxidative pathways, suggesting a common underlying mechanism in some cases.
Yes, this is a profound shared insight. Importantly, both arterial and venous thrombosis may be triggered or exacerbated by pathophysiologic stimuli responsible for activating inflammatory and oxidative pathways. This suggests a common underlying theme of systemic inflammation and oxidative stress contributing to the risk of clot formation, regardless of whether that clot ultimately forms in an artery or a vein.
So inflammation is a common enemy here.
A very significant one. So while the immediate triggers and clot compositions differ, the broader systemic environment of inflammation and oxidative damage can prime the body for clotting in either system.
We've truly journeyed through the complex, vital, and sometimes terrifying world of blood clotting today. From the minute a nucleate platelet orchestrating the rapid formation of arterial clots to the sprawling and amplifying coagulation cascade forming the fibrin-rich venous ones, we've seen how these distinct yet sometimes overlapping pathways govern our very lives, constantly maintaining a delicate balance.
Understanding this intricate balance isn't just academic, it's key to appreciating both our body's incredible defense mechanisms, like stopping a bleed, and its profound vulnerabilities, where those very same systems can tragically turn harmful.
Yeah.
It's a testament to the sophistication of human biology, a system designed to protect us, but one that can also, under certain conditions, betray us.
So, as you reflect on this deep dive, consider this provocative thought for your own future understanding. Given the profound genetic variability we discussed, especially in how individuals respond to crucial drugs, that fascinating field of pharmacogenetics, how might personalized medicine evolve to prevent and treat thrombosis even more effectively in the future?
That's the big question.
What questions does this raise about preventative health and the potential for tailoring medical advice, not just to broad populations, but to your individual biology, your unique genetic makeup?
The more we understand these nuances, the more precise and effective our interventions can become. It's a future where your unique genetic blueprint could guide your specific treatment and prevention strategies for these widespread and often deadly conditions, moving beyond a one-size-fits-all approach. It's a truly exciting frontier in medicine.
Thank you for joining us on this deep dive into the fascinating, life-saving, and sometimes life-threatening science that governs our very blood. Keep asking questions, keep exploring, and keep being curious.